Hello, good evening, everyone. We are starting with the Ganesh Vanda.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Hello, good evening, everyone. Welcome, Dr. Bharti. Over to you, ma'am.
So good evening, everyone, and welcome to the webinar organized by the Chandigarh chapter of NIGF. I'm highly thankful to Dr. Ragini, who has given me this opportunity, and she's pushing all of us definitely that we should basically have a sessions on different aspects of the webinar. So now today we have chosen a chapter and starting with the aneuploidy screening, and we do all understand that this is a pillar of all antenatal care. So before we start, we would like to seek blessings of our Dr. Ragini. Dr. Sharda Jain, I think she has not joined. So Dr. Sharda Jain, she's the teacher of teacher, founder and secretary. And then Dr. Ragini Agrawal, madam. So madam is a founder president Association of Obs and Gynecologist Haryana, and she has so many other contributions and awards and many publications. So I would request Dr. Ragini Agrawal to first bless us and guide us for further also. And Dr. Ragini Agrawal, please.
Thank you so much, Bharti, and thank you, Chandigarh, for really joining and doing this webinar. What I can only say that Chandigarh is going to invite all of us again for the annual conference on 18 to 19 July. And second thing, which I always say, we need more and more members for NIGF, and consider on your Aadhaar card always the address of your parental home. आप कहीं भी होते हो, वो सब आपका टेम्परेरी होता है, और आपके आधार कार्ड पे आपका पेरेंटल होम का एड्रेस होना जरूरी होता है. वैसे ही you should be the member of this regional association of North Indian OBGYN specialist, which we have made to exchange the academic excellence, medical legal safety, and our own networking. So with these words, I will not stand in between the academics and you. Over to you, Dr. Bharti. Please continue your excellent academics. Thank you so much.
Thank you, ma'am. Thank you for your words of inspiration. So without wasting much time, I think we should move to our first session. So that is a talk. The talk will be taken by my dear colleague, Dr. Snigdha. Dr. Snigdha is additional professor of PGI. She's a fetal medicine
you need to impart your patient and need to act aggressive.
She's a fetal medicine expert. So many publications.
Not audible. I can't hear.
Hello?
I can't hear anything,
I
doctor.
think noise removal is on mute. It is showing. Please just check. Can you check, please?
Audio is okay, ma'am. Your audio is audible.
Okay, because saying that they are not able to actually hear me. Am I audible?
Yeah.
I'll rejoin. I can't hear anything. I'm sorry.
It's audible. You're audible, Dr. Bharti.
Okay.
Achha, okay, ma'am. So we will be starting with the first talk, that is, aneuploidy screening in the first trimester. Beyond basics, will be definitely Dr. Snigdha will be explaining each and every important aspect, that how we have to individually and give the importance to the analytes. So before and then for the chairpersons for this talk, Dr. Navneet, she has already joined. Dr. Navneet, welcome to the webinar. Dr. Vineet Nagpal, are you there? Dr. Meenakshi was stuck actually with the rounds and some emergency, so she has conveyed me the message that.
Hello, Dr. Bharti.
Oh, Dr. Vineet, hello, good evening.
Dr.
Yeah, you are audible. Well, Dr. Vineet, and then Dr. Ruchi Rai. Dr. Ruchi Rai?
I can't see her as
probably she will join. Achha, okay, so Dr. Navneet is there and Dr. Vineet Nagpal is there. Dr. Meenakshi and Dr. Ruchi Rai probably will join soon. So we can start with the talk. Snigdha, over to you.
Thank you so much, dear ma'am. I'll just start sharing my screen. Is my screen visible to all?
Yes.
Yes,
Dr. Snigdha.
So,
Good evening. Very good evening. Welcome for the talk.
good evening, dear ma'am.
Hmm.
Okay. So, thank you for giving me the opportunity, and I would not delay further. So, starting with a very important topic in today's scenario is one of the important things which should be universally done for all the patients in antenatal OPD. So, it is fetal aneuploidy. So, screening and further testing, how we should go about it. So, I have taken all my uh, actually reviews from here, from the ISO guidelines as well as from the ACOG and other Society of Fetal Medicine. So now, getting ahead, what we learned today is having an overview of fetal aneuploidies and the mechanism how it happens. So more mainly for the downs, and review the first trimester markers and ultrasound protocols given by all the bodies, bigger bodies, and compare screening versus diagnostic options, learning algorithm, how to decide, how to clinically make a decision regarding whether to go for a screening test or diagnostic test following a screening one. And also we should know about the Indian practice and the FOXI specific guidelines. So the definition of aneuploidy, as you are all aware, is abnormal number of chromosomes, and it mostly started with a screening of Downs, and it was way it was way behind that we heard the description of Down syndrome in 1866 by John Langdon Down, and thereafter, however, the first ultrasound, which was the first karyotype which was done, was done on amniotic cell culture, and it was way beyond in 1966, almost around 100 years later. And moreover, the first ultrasound which was done on fetus was done in France. It was in 1974. However, it took us more years further to learn how to screen a patient, because before 1980, it was that all the patients, usually only 5% of patients used to be more than 35 years of age. That is, we used to call them elderly, and they directly underwent amniocentesis for the same indication that they had an increased chance of aneuploidy. So nowadays, in today's scenario, when around 1/4 of the patients are already more than 35 years of age, putting needle in all the patients is not a wise decision. So screening and segregating the high-risk population followed by diagnostic testing is the main motive nowadays. So we embarked on the screening criteria at around 1980s, when second trimester alpha fetoprotein and triple marker was actually came into scenario. And thereafter, in almost 10 years later, we embarked upon the first trimester nuchal translucency, along with combining it with the biochemical markers. And then in today's scenario, we have still made further development in the form of cell-free fetal DNA. So he is the person who first talked about Downs, and we should all know why Downs is important and why all this aneuploidies is mainly actually concentrated to Downs, is that usually these aneuploidies are associated with these aneuploidies are mainly associated with many problems, like cases of infertility, like cases of RPS, like they have many deformities. So we should know that nearly 60 to 70% of trisomy 21 fetuses usually show some structural defects or soft markers. And so we should go beyond that and screen these patients earlier, even in the first trimester. So what is the pathophysiology behind this screening is, there in cases of Downs and other aneuploidies, that is 18 and 13, and I'm mainly talking about Downs pathophysiology, that is, there are abnormal trophoblastic function, and there is hyperproliferation of trophoblast, which can lead to increased beta SCG, and usually placental dysfunction in these cases lead to altered PAPE, that is low PAPE, and the fluid imbalance and all the lymphatic disorders lead to increased NT. And so these are the important markers in aneuploidy screening for fetuses. And early structural defects can also be, nowadays with advanced technology, can be seen from 11 to 13 plus 6 weeks. So coming to first trimester screening components, the optimal window for this is 11 to 13 plus 6, which include the ultrasound markers. And the highest body which says is what I follow is ISWOG. So it says that NT, NB, combining DV flow and tricuspid regurgitation, usually what it does, it increases the sensitivity to almost 95% with a false positive rate of around, say, 3%. So it is the highest thing which can be highest markers on ultrasounds, which can be combined with all the biochemical markers in the first trimester, that is including PAPA and beta SCG, and we can get a good screening result. So now this alone is not enough. We combine also maternal factors and the history, and there are optional additional markers which we can also combine to get a very good result. But then this is not included in the standard guideline. That is fetal heart rate. Whenever there is tachycardia along with increased NT, there is increased chances of trisomy 21 and trisomy 13. But whenever there is bradycardia on the fetal in the ultrasound around 11 to 13 plus 6 weeks when we are doing, so along with increased NT, there is a chance that it is associated with trisomy 13. So we should also keep an eye on the fetal heart as well. Apart from that, there is frontomaxillary angle, nasal bone length, tricuspid regurgitation, velocity. So moving on. Now coming to first ultrasound marker, that is nuchal translucency. We all know that there are certain standard guidelines which should be followed while doing it, and this should be done by a radiologist who is trained basically into this ultrasound. So the magnification should include the fetal head as well as thorax. It should be a mid-sagittal view. The fetus should be in neutral position, and there should be calipers which uses the maximum precision, that is 0.1 mm, and the caliper should be placed at the inner border of the horizontal line. So the widest translucency is used to measure the nuchal translucency. So what we see here in this table is if the nuchal translucency is less than 95th centile, so the chance of having chromosomal defect is only 0.2%. However, you can see very well here, let me use the marker, as it increases to 3.5, the chance of having a chromosomal defect increases abruptly from 0.2 to 21%. So, and the chances of having an alive and well fetus after nuchal translucency of more than 6.5 is hardly 15%. So, nuchal translucency is the major component. However, if NB, TR, DV is not included, it is a must to do NT scan. So, apart from the aneuploidies, increased NT is also associated with major cardiac defects, sometimes diaphragmatic hernia, exomphalos, body stock anomalies, and sometimes other genetic syndromes apart from the aneuploidies, that is congenital adrenal hyperplasia, fetal akinesia sequence, Noonan syndrome, spinal muscular atrophy, and so on. So this is a very busy slide, but I'll tell you the gist of the slide that in cases of euploid fetuses, whenever the NT is more than 99th centile while using the nomogram chart, and we have ruled out all the aneuploidies and our karyotype and CMA comes out to be normal, still one of the studies, including around 2 lakh population with NT scans, actually said that even if this is the euploid child and the NT was more than 99 centile, there is an increased risk of intellectual disability and autism spectrum disorder. So we should pay very much attention to the increased NT, and this is followed by the NB. So nasal bone, it uses the same magnification, same view, and there should be 3 distinct lines, echogenic lines, one of which is nasal skin, beneath which is the nasal bone. And if the nasal bone appears as thin as less echogenic as the overlying skin, it suggests that the nasal bone is not yet ossified and it is classified as being absent. So now coming on to TR. So now we get a 4-chamber cardiac view. Pardon? So we take a 4-chamber cardiac view, and in the 4-chamber cardiac view, we hardly use the color Dopplers here. We don't use the color Doppler. We just put the pulse wave Doppler, and then we use then we actually get the flow pattern, and then it should be in between -60 to +60. The waveform should be in between this velocity. So if it goes beyond -60, so it is said to have tricuspid regurgitation, and the insonation angle for all these Dopplers should be less than 30 degrees. So now TR is only found in 1% of euploid fetuses. So if we get tricuspid regurgitation, it is one of the signs that suggest aneuploidy, and it is found in around 55% of fetuses with trisomy 21 and in 1/3 of fetuses with trisomy 18 and 13. So including TR actually, as I said, increases the sensitivity of detection for trisomy 21 from 90 to 95%. Now coming on to ductus venosus, it is the same gestation in which we do it, in which we screen it. For this, we use the color Doppler. And wherever there is area of maximum aliasing, that is brightest signal, we put the Doppler on, and then we get a wave pattern. And so in this wave pattern, actually, the pulse repetitive frequency should be adjusted between 50 and 70 so as to get a good wave pattern, and so that the A wave is not obscured, because A wave is hard to find at that gestation. So whenever there is the A wave is absent or it is reversed, it is said to be associated with some anomaly, some aneuploidy, or as well as cardiac malformation. So interpreting ductus, we put this data, that is whatever we get in the DV, we put it in the combined screen, and then whatever we are getting, it is not a direct indication for doing amniocentesis or CBS or any other invasive testing. So we just combine it in the combined test, and then whatever we get the result. So the diagnostic testing is based on that result. But still, a fetal echo is must, and an anomaly scan is must. So now looking at the ISOF protocol, what is suggested is the crown rump length should be between 45 to 84. It should be a mid-sagittal section, as I said. And the nasal bone should be either written as present or absent. There should be DV. And tricuspid regurgitation valve Doppler should be included in this. And we should also otherwise include an early anatomy review, including the brain, spine, stomach, bladder, extremities, and so on. So getting on to the biochemical markers now. Enough about the biophysical markers. The biochemical markers include beta-SCG in the first trimester. And however, as I have mentioned here, the second trimester also includes certain biochemical markers like alpha-fetoprotein, unconjugated estriol, and inhibin A. And this table shows what are the values actually in all the trisomies, that is aneuploidies, and the neural tube defects. So in trisomy 21, the beta-SCG is increased, and it is increased beyond 2 moms. So what value we need to remember is for trisomy 21 is beta-SCG more than 2 moms. And what about alpha-fetoprotein unconjugated estriol? It is less in trisomy 21, and inhibin A is increased in trisomy 21. So it is beyond 1.75. So coming to trisomy 18. Trisomy 18, here beta-SCG is decreased, and all the levels of alpha-fetoprotein as well as unconjugated estriol are decreased. So this chart actually summarizes all the aneuploidies along with the biochemical markers as seen here. So now moving on to the PAPE pattern. So why PAPE pattern? Because then we were talking about the first trimester screening. First trimester screening actually includes beta-SCG and PAPE. So PAPE, we'll note something about in detail about PAPE, that trisomy 21, it is decreased. So how to remember PAPE is actually it is decreased in all the trisomies, and also decreased in Turner's, that is 45X, monosomy X, and also normal or decrease in triploidies, be it diandriac, that is from parental chromosome, or be it digynic, that is from maternal chromosome. So in all cases, we need to remember that PAPE is decreased. And what is the value which we need to remember is less than 0.415 moms. So for all the cases, it is the same. So in case if PAPE is not associated and with aneuploidies, we have ruled out all the chromosomal anomalies as well as the genetic defects. PAPE, low PAPE is always associated, is not always, but it is mainly associated with fetal growth restriction later on. So now, What we need to remember here is, I have summarized it in one table. So NT should be less than 95th centile for that gestation. And what is the high risk pattern? It is more than 95th centile. NB should either be present or absent or hypoplastic. And DV, what about DV? There should be normal A wave, and high risk pattern is reversed A wave. What about tricuspid regurgitation? Either it is absent or present. If it is absent, it is normal. In high risk pattern, it should be present. PAPE value is, as I said, less than 0.4 moms. What it is high risk pattern, and it should be more than 0.4 moms to be normal. So beta HCG normal is 0.5 to 2 moms. And what is the high risk pattern is, it should be more than 2 moms. So now, coming to combined first trimester screening, what it says is the detection rate actually for the combined first trimester screening is to the tune of 90% for trisomy 21 and for all the trisomies as well. However, with the false positive rate of 5%. Now, as I said, if we combine the other biophysical markers, that is TR and DV, along with the biochemical markers, routine biochemical markers for first trimester, the sensitivity actually improves and goes on to 95% with the false positive rate of 3%. So in India, we usually use combined first trimester screening with all the biophysical and biochemical markers. And NIPT still is not universal in India. So few words about NIPS or NIPT or cell-free fetal DNA screening. Actually, it is the best screening test for trisomy 21. However, not for other aneuploidies or not for other genetic abnormalities, but only for, while we are recommending this to our patients, we should usually tell them that it detects trisomy 21 to the tune of 99%. However, the sensitivity of other screening other aneuploidies is not as high as trisomy 21. However, there is a limitation in our country with the cost, because the cost is high as compared to the combined screening. So, but however, we should know at the end of the day that it is not diagnostic test, be it 99% sensitive. If it comes as positive, we need to go for a further confirmatory test in the form of invasive testing, that is, be it CVS, chorionic villus sampling, or be it amniocentesis. So there can be false positive, which is usually common in confined placental mosaicism, wherein the and vanishing twin and maternal malignancy and obesity. Now, actually talking about vanishing twin, what happens is whenever there is vanishing twin, usually what happens is it happens in the first trimester, and whenever it happens, the most important cause for vanishing twin or the miscarriage of this twin is genetic abnormality. And whenever there is genetic abnormality, what happens is all the fetal DNA from this vanishing twin goes into the maternal stream. And what happens is the NIPS actually gets more fetal fraction from this vanishing twin, and hence we get the false positive results. So in maternal malignancy as well, there are increased maternal DNA, and with the tumors causing more of beta HCG and all these things. So, and in obesity as well, what happens is there is low fetal fraction, and in the IVF conception as well, there is low fetal fraction. So all these results can lead to false positive, and it is common in these conditions, which I have already stated. So what is the ISOG recommendation for cell-free fetal DNA? However, it says that it can be performed as the primary screening from around 10 weeks onwards, but still we need to perform the fetal anatomy scan, which is known as the NTNB scan in common language in our country. So the first trimester anatomy scan is not a substitution for the primary screening with cell-free fetal DNA. So it is mandatory, be it cell-free fetal DNA, be it combined testing, we need to go for a first trimester anatomy scan. And in twins, the sensitivity, as we know, is slightly reduced in cases of cell-free fetal DNA if we do the screening with the same. So what if there are no call NIPS results? We don't have any result, and you might have come across these kind of results. So the causes can be, as I said, there can be low fetal fraction, it can be maternal obesity, there can be early gestation if we have sent it too early, and there can be chances of fetal demise. So how do we manage? We manage by sending either repeat sample, we can counsel the patient, post-test counseling is there, and we need to counsel the patient to repeat the test, or either we can offer them a diagnostic testing. So what are the diagnostic testing in our scenario? It is either CVS if we have done the NIPS or done the first trimester screening early and we get a high risk for the aneuploidies, we can go for CVS, which is done at around 10 to 13 weeks. So what are the advantages with this? The advantage with this is early result, early termination, no mental agony for the mothers, and with amniocentesis, however, we do it later, but one of the advantages with amniocentesis is there are fewer mosaicism issues, because then in cases of CVS, what we do is we tend to sample the placenta from a certain place. So we are not sampling whole of the placenta, and that is why there can be mosaicism, and it can lead to no-call results. So, and the procedure-related loss, ours is a very high volume center, so we are doing these procedures day in and day out. We can say that it is comparable in both the scenarios, whether be it CVS, be it amniocentesis, the results, the procedure related loss is the same. So now what to order after CVS or amnio? How do we go about it? What test do we order? So QF-PCR is a rapid aneuploidy screening test. So diagnostic test, and so the result is out in another say 3 to 4 days, and then you can reassure the patient that the major aneuploidies are now ruled out, and however we need to go for further testing in the form of chromosomal microarray. So what it will take another 14 days to come out, and but then sending QF-PCR is good enough to make the patient aware that now they are not having any aneuploidies, but then there can be chances of some genetic malformation, which is a very rare scenario. So for any structural anomalies and getting a normal CMA, so we can order whole exome sequencing later on if the results of CMA comes out to be normal. So now, how do we go about it? So we offer aneuploidy screening to all women. It should be universal. And then we offer diagnostic testing. We do not, in Indian scenario, we do not, however, offer diagnostic testing to all women irrespective of age. But then it is said, if we do a pre-test counseling and the women, irrespective of her screening, wishes to go for a diagnostic testing, we need to offer her that. So we need to do a pre-test counseling and a post-test counseling, which is very important, with a geneticist sitting beside us as well. So, but then do not ever combine multiple screening tests, like doing a first trimester combined screening, which has come out to be low risk for that woman, and then again asking her to go for a quadruple screening should not be done. But if in case you're doing an integrated screening, then if you're not telling the result of the combined screening to the patient, then you can go for quadruple screening, and then combining together, you can take out a result and then you can tell the patient. But in our scenario, this is not usually done. And hence, we should not go for 2 tests simultaneously, giving the first trimester screening, combined screening, as well as asking her to go for a quadruple screen. So if you want to go for one test, you can either go for cell-free fetal DNA, and doing an NIPS is good enough. But if the patient is actually ready to give the cost for the same. So now, if the screening comes out to be positive, as I said, post-test counseling and doing an invasive confirmation is what needs to be done. And for fetal anomalies, you need to send CMA, which is preferred over karyotyping. So in our scenario, in Indian scenario, usually we offer NIPS if the woman is more than 35 years and there is a previous child with aneuploidy, or it is a positive combined first trimester screening. If the patient doesn't want to go for, we need to individualize the patient. If the patient doesn't want to go for an invasive testing, we can offer her a better screening test as compared to the first trimester screening test. So in these scenario, if say the patient is 40 years of age and the patient is having IVF conception, so if the patient is not ready in that scenario for an invasive testing, we can offer her NIPS in that case. So now with the positive NIPS, we must do a diagnostic testing, as I said, and the flow chart goes like this. Offer counseling, discuss options, and after the screening options, if she has chosen one, go for it. And then the screen comes out to be positive, we do a invasive screening, invasive testing. So there are certain situations where we need to interpret. If the NT is more than 95th centile, she is high risk, either offer an IPT or do a CVS straight away. Fine. So however, if the NT is not more than 95th centile, do a combined screening and go ahead with the numbers as seen here. So what we call as high risk is 1:2, more than 1:250. So for positive NIPT, the algorithm goes like this. If positive NIPT, always confirm with invasive testing. And if the CVS is normal, but suspicion persists, you have to go for amniocentesis in that scenario. Because when a CVS is done and there is confined placental mosaicism, or there is no result is happening and DNA culture has failed, so you can go for amniocentesis again and offer a CMA, especially if there is anomaly in the baby. So special situation is if NT is more than equal to 3.5 mm. However, regardless of the NIPT result, you have to offer a diagnostic testing to her. And in cases of twins, we already know now that there is low positive predictive value, especially in the dizygotic twin. So what is the best thing is in twins is to go for a combined first trimester screening. So without this, actually, we can offer, if it is not done, if we miss this window, we can actually go for cell-free fetal DNA. But then quadruple screen should not be advised in this case, in cases of twins and higher order pregnancies. So now what ISOX has to say is chorionicity is mandatory for these twins, and in cases of vanishing twin, we need to avoid NIPS, as I already mentioned why. So in our practice considerations, we have limited NIPT availability in some regions. So, and there are cost constraints, as I said. So the best thing for us is to go for a combined first trimester screening. And this is the comparison.
Snigdha, I think Dr.
Yes.
Snigdha can, time is...
Yes, ma'am. Yes, ma'am. This is the second last slide. So timing is the same. Timing is the same for all these. And yes, the detection rate is the highest with NIPS as compared to others. And obviously, diagnostic has the highest result. So invasive, yes, diagnostic. So false positive rate is the lowest with NIPT, as I said earlier. So NIPT seems to be the best, but in Indian constraints, so we still go for combined first trimester screening. So as I said, mosaicism, the strategy is if CVS is abnormal, then perform amniocentesis. And the one slide I wish to mention is major structural clues are towards the aneuploidies are holoprosencephaly for trisomy 13, omphalocele for trisomy 18, megacystis for 13-18, congenital heart defects for 21-18, and limb abnormalities for 13-18. This is what we need to remember while doing the 11 to 13 week scan, the first trimester scan. And so our aim actually is to have an uncomplicated birth of a healthy fetus to a healthy mother at term. So that is why all these discussion still prevails, and we actually move on to having good screening and good diagnostic testing, and it should be universal. So thank you, everyone, for your patient listening, and I'll stop sharing the screen.
Thank you, Dr. Snigdha, for a very elaborate and very nice talk. I'll just take, say, 1 more minute and give some practical points which from the clinic we are running. So when I went through literature, the first sentence which struck me is that every mother or couple has the right to know the health status of their unborn child. So that is our approach. We want to tell them that you are having a healthy child. So this is their right. And by doing all this testing, I think we can give them a fair idea. Number 2, whenever we do this, we should always perform a pre-test and a post-test counseling. Third, in the NT-NB scan, if TR and DV flow, I think Ashish will agree with me, if they are added, it's a wonderful asset. Then in some cases, they will write NT 95th percentile. So you want to check. Then you go to perinatology.com, put in the NT, put in the CRL, and it will give you what percentile the things fall in. Then there are 3 types of screening: contingent, sequential, and integrated. We follow the contingent, in which we do a first dual test and a NT-NB scan. And mind you, I recently, in a 1 month back, faced one patient who had come to me, Doctor Sahab, I've had a Down's child, but I want to know whether there was any mistake. I got an NT-NB and then level 2, which was normal, but her reporting of the dual marker was not good. 1 in 250, and she was not counseled for that, and she was carrying a Down's baby. So please tell your patients that both is required, dual marker and NT. एक कर लें दोनों में से? No, it is, we have to emphasize कि हमें दोनों चाहिए, बायोकेमिकल भी, मतलब एनालिट भी चाहिए और ये भी चाहिए. So that's
just one point. I wish to make a point that there are few labs who are actually doing dual screen, but then are not combining the results for NT and NB along with that. So it is very important to tell the patient that get an NT and NB scan done, then go to a lab where they accept this result, the NT and NB values, and then they go on to do a combined screening rather than just giving you the result of biochemical screen. So this is very important to tell them in the pre-test.
My last practical tip is that whenever you are asking a patient to get an NIPT, which is a very costly test, as the first screening test, suppose patient says, no, doctor, I want one which has more sensitivity, I can afford anything. Then always get an ultrasound first, because vanishing twin has to be really ruled out before this all literature says, before you embark on a NIPT. So a scan before NIPT is a must. Thank you. These are the tips I wanted to say. Dr. Vineet, over to you.
Dr. Navneet, can I make a comment?
Yes.
So from a practitioner point of view, there is 2 things very important. Most of the practitioners, they really see the only report and not anything. We should know what is the mom. That is very important. Sometimes mom out of the limit, either less than 0.5 or more than 2.5, give you some other indication also. It is beyond aneuploidy. And number 2, we have to really see one more thing. If it is the intermediate zone, as you said, it is just one, can say 1:250, but it is 1:300. That patient has to be followed.
Also, yes.
Because they can land up. And the third thing, recently in the fetal medicine meeting, there's an international fetal medicine expert has come, and what she said that we should not jump directly to NIPT. It's still a dual marker has a more value than the NIPT.
Yes.
I was going to just say the same. That I think dual test and a very good NT-NB scan has much more, much more reliable than doing the NIPT. And maybe giving a false hope to the patient that everything is normal. So, and the scan should be done by an expert. That is very, very important.
That is very important, ma'am. That is the most important thing.
Even if you have to wait for a while for the exact positions and everything.
Yes.
So before giving any kind of report, I think that is very important that experts' hands should do the scan. Because that is the take.
So after this combined testing, as Dr. Ragini mentioned, we have to do whether the patient falls in high risk, whether she falls in intermediate risk, or she falls in low risk. So that's contingent screening. That's called contingent method of screening.
That is maternal age as well as maternal history is very important. Most of the time, the history is not incorporated into the result. So I think Snigdha has done a very good job. Very good job.
Thank you.
Excellent presentation.
Excellent. Yeah, really.
Thank you, ma'am.
Thank you for making me a part of it, Dr. Ragini, ma'am. Thank you.
I would like to put a point. Initially, may I?
Yes, why not?
Initially, it used to be when we were like, initially it used to be high risk category. We used to categorize patients. Only those genetic counseling we used to do for only high risk patients. But now the latest guidelines, and it should be made. Yes, it is mandatory, and all pregnant patients, irrespective of maternal age or baseline risk should be offered first trimester screening. And rightly said, ultrasound definitely matters, because one right ultrasound definitely helps a long way. Dual test, whenever we offer to any patient, the first thing that we tell is first you have to get your ultrasound done. That report only, after that report only, we'll be doing the blood test, because obviously it has to be a combined test, and then only you can give what is the percentage, how well is the pregnancy going on. You cannot actually comment upon baby status based on only one blood report. I don't know about the labs, Snigdha, which is not giving anti-scan, not doing anti-scan and just giving dual test. But ideally, it should
I
always
must
be
not
anti.
disclose over
It's
here, but
all,
there are
yes.
labs which are not
Because
including it.
that is
most
like
of them,
mandatory. Combined, it has to be like that. It should be the other way around. It has to be the ultrasound first, and then the blood serum samples should be
Actually,
combined
ma'am,
to that.
the one of the best labs where we used to send biochemical, all the biochemistry reports and everything, they usually don't combine the NT as
And
the NT
maternal
screen.
age matters.
That is Lal Path lab, ma'am.
It
They
is,
never
it is
combine.
not a complete test then. If they don't combine it, then it is no fun.
Yes, ma'am. It is of no use, because then
Then it is not the,
there's no
what
point.
we say.
no point in doing it.
There's no point.
Because
Even small
because
things.
because dual screen only has 60% of sensitivity.
And the thing is, to add on to that,
I
there is
think we
small.
go for the panel.
Yes, I
Yeah,
think
yeah,
more
yeah.
clarification.
Yeah, we
of
go
course,
for the
of course,
panel.
yeah.
Time is
Yes,
short.
time is short. I think it was such a brilliant talk by Dr. Snigdha and inputs by our experts. So moving to the further challenging clinical scenarios, we have radiologists also, we have a fetal medicine our panel, and we have a woman imaging experts also, infertility experts. So I would like to invite Dr. Ashpi and Dr. Navdeep. Both are consultants, senior consultants in Motherhood Hospital. So they will be, having a discussion on challenging clinical scenarios. Expert is Dr. Monica with us. And we have a panelist, Dr. Ritika, a senior consultant, fetal medicine expert from AIMS. She's working at present in Cloud9 Hospital. Dr. Ashish, he's our PGI alumni and he's an expert in women imaging. Dr. Vidhi Hathi, she's our ex-resident who had done fetal medicine from Chennai. Then Dr. Nidhi is not able to join. Dr. Kanchi is there as the infertility specialist from Cloud9 Hospital. And Dr. Annie Monga, she is our high-risk pregnancy fellow. So I think Ashpi and Navdeep, we can go ahead with the discussion, right? Ashpi, hello.
Good. Yeah. Good evening. Dr. Navdeep here. Hope
Dr.
you
Navdeep, yes.
Dr.
Navdeep, yeah.
Hope I am audible to everyone. Good evening to all my seniors and colleagues. Okay. So Dr. Bharti has given all the Dr. Bharti has introduced everyone. So this was the learning objective, as Dr. Snigdha has already elaborated it. This is our first case. She is a primary, 32-year-old at 13 weeks, 1-day gestation. Her CRL is 70 mm. Her NT is 3.1. Yes. Hello.
Sorry for the interruption. Can you make it full screen?
Full screen.
Yeah, sure, ma'am. Sure.
So put on slide.
Yes.
Thank you.
Yeah. So she's 32-year-old, primary gravida at 13 weeks 1 day with CRL 70 mm. Her NT is 3.1, which is 2.3 mm, and it is around 99th centile. TAP is 0.99 mm, which is a little lower. Beta STG 1.37 mm, which is a higher normal. But final calculated risk for trisomy 21 is 1:115. And trisomy 18 and 13 risk screen is negative. So this is for Dr. Kanchi. What makes this report clinically significant? despite relatively near normal biochemical markers, and why these near normal biochemical markers are not as assuring enough in this case? Dr. Kanchi?
Kanchi, Dr. Kanchi?
Am I
Dr.
audible now?
Kanchi, you're not audible.
Yes, Kanchi?
Am I audible now?
Yes.
Now, yes.
Yeah.
So, here,
Hello, Dr.
my
Kanchi?
Papa is okay. Ma'am, am I audible?
Yes, now you're audible.
Ma'am, I think my signal is on and off. I will go to Dr. Ritika's room maybe. Then I am...
Dr. Ritika, can you take up the question? I think if it's okay with the moderators.
Yeah, I'd be happy to if it's okay with the moderators.
Yeah. Sure, ma'am.
Yeah. So
yes, Dr.
anytime it is more than 3 mm, I think it is kind of a red flag. So even though the HCG and PAPE norms are close to 1, that is their near normal. But NT is also an indirect marker of other things besides trisomy 21. And you can have other genetic abnormalities also, other chromosomal aberrations, other microdeletions and duplications, and structural abnormalities, which can be associated with a high NT. So I hope that answers.
Yeah. So this basically increase NT modifies the whole baseline risk, leading to the a value of 1:150. Next question is for Dr. Ashish Dua. How should NT of 3.1 mm at CRL 70 mm be interpreted, and what are the common cause of false positive first trimester screening?
So an NT, ma'am, of 3.1 mm will usually be on the higher side. I think it is always advisable to look at the centile charts. And for a 70 mm CRL, a 3.1 mm NT should be easily above 95%. And even if we use a ballpark figure, I feel that any value above 3 should be treated with suspicion. And if it's between 3 to 3.5 mm, it is likely to be more than 95th centile. And if it is more than 3.5 mm, that actually makes it more than 99th centile. And it has a strong association with trisomy 21, Turner's, cardiac defects, and other congenital anomalies, including single gene disorders. As far as the false positives are concerned, then as Snigdha ma'am had clearly mentioned, that first we need to measure the NT properly. There's a proper technique which has been defined by the FMF guidelines. Secondly, the dating should be accurate. If there's a discrepancy of more than 1 week, then we might get a false positive result. Thirdly, maternal obesity and diabetes can actually cause metabolic changes and false values of beta HCG and PAPE, which ultimately might result in a wrong or a falsely positive combined screen. Then again, as Snigdha ma'am had told, a vanishing twin. So because of this vanishing twin, there can be a falsely elevated beta HCG and PAPE, and also the IVF pregnancies.
Thank you, sir. Next is for Dr. Vidhi. What should be the immediate next step in this patient?
Good evening, everyone. I hope I'm audible.
Yes, ma'am, you're audible. Yeah. Yes.
So, my next clinical step would be first to sit with the patient and talk to the patient and counsel the patient. Tell them that, first of all, their nuchal translucency is increased. Their first trimester screening result is positive. What made the screening result positive? And then, my first option of further care after I have counseled the patient would be to actually offer direct testing. Since the first trimester risk result is also positive because of an NT of more than 3 mm, and as we discussed before, the NT of 3 mm, which is more than 95th centile, is what is concerning. It is not just something that a secondary screening would pick up. Yes, we need diagnostic testing. Third, what we need is that if in addition to a diagnostic testing, we need an early anomaly scan, because an increased NT can, as we discussed, also be associated with cardiac abnormalities, other structural abnormalities. So an early anomaly scan at 16, 17 weeks and a detailed assessment of the fetal heart. Now, if the patient is not willing for diagnostic testing at this point, and the NT is between 3 to 3.5 mm, which is actually between the 95th to 99th centile, NIPT can be considered as an option, but they need to understand that NIPT is a poor substitute in this scenario, because it will only tell me, it will only screen for trisomy 21, not even diagnose it. Really, it does not have a good screening for anything else other than trisomy 21. And so this will be my counseling, and we'll take it further as the patient decides.
Yes, so in this case, we'll offer a detailed genetic counseling, and we'll give a patient option of mainly diagnostic screening, not screening, diagnostic test for definitive diagnosis, and then also plan for early anomaly scan followed by fetal echocardiography. This question is for Dr. Ritika again. Ma'am, how do you explain the risk of 1:115 to patients? And beyond aneuploidy, what are the other conditions that cause this suspicion of raised NT?
Yeah, hi. So whenever a patient comes with this kind of a report, we kind of break it down. So 1 in 115 means that only one woman out of 115 with the report that she has will have a baby with trisomy 21. So put it simply, it's around 1%. So there's a 99% chance that the baby will not have Down syndrome, even with this high risk, but the risk is actually higher than the cutoff that we use for offering further testing to the couple. And so yeah, and the next thing is, what are the other conditions it can be associated with? So the most common obviously are the common aneuploidies, but then there are microdeletions and duplications, DiGeorge and all, which can have a higher NT. And there can be single gene disorders also. I think it's a very big gray area as to where do we stop the testing, but there is an association of an increased NT with single gene disorders, mainly rhizopathies and the Noonan syndrome group. And also there are other conditions. There can be congenital cardiac defect in the fetus. There could be some skeletal dysplasia, or there could be some lung conditions like congenital diaphragmatic hernia, which can be associated with an increased NT. They all have different etiopathogenesis. Like with lung problems, there can, and with cardiac problems, there can be backflow. And with the Turners and Noonans, there can be lymphatic abnormalities. So the etiopathology and the pathogenesis is different, but there are a lot of conditions besides trisomy 21 which can have a high NT.
So will we ask the patient
I would also
to
just
go
like to comment on one thing. I think fetal infections, in my personal experience, I don't think per se that they are associated with a thick NT, but maybe there's some isolated case reports. But because then if you're saying fetal infection, it's a completely different line of counseling and a different line of genetic testing.
If the patient is asking for CVS, or we are going for amniocentesis, would we like to send CMA, just CMA, or a whole exome sequencing in this specifically case? Because just NT is high, rest of the biochemical markers are near normal.
So look, I'm sitting in a private setup, and in many cases, cost is not the major issue. And if you're putting in the only reason of not sending an exome sequencing is financial. Like if you take the finances out of it, there is no reason why, if you're putting in a needle and you're taking out the baby's DNA, you do not send testing beyond microarray. But obviously, when we send exome, we always send a trio exome, so the cost does amplify a lot. At 3.1 mm, maybe not. Maybe I'll just stop at microarray. But then a lot of times it's about counseling and what's their family history. Is there a history of consanguinity? Do they have a history of any prior child with disability early in your natal?
She's primigravida.
Yes. So at 3.1, probably not. No, not exome in this case.
Okay. Thank you, Dr. Ritika.
Also, if I can add to what Dr. Ritika said, yes, at an NT of 3.1 mm, a sequential testing might be more appropriate than sending all tests. That is, a microarray first, then an early anomaly scan, and then a rediscussion as to whether an exome is needed.
So here, I think the debate will be again already, this has been discussed for Dr. Annie Mukt, ma'am, NIPT or CVS. What would you recommend? And in invasive testing, I will say whether CVS or wait for amniocentesis.
So thank you first of all for inviting me. So this patient is already having a high risk in her combined screening test, that is less than 1:250 risk, that is 1:115. So considering that is a high risk in the screening test, and the patient is having an increased nuchal translucency that could be associated with other single gene disorders also. And NIPT is only giving us data for chromosomal anomalies that too increased with 99% sensitivity for trisomy 21 and lower than that for the other chromosomes. So I would counsel the patient regarding invasive and diagnostic testing rather than going for NIPS, which is another screening test. And as for CVS or wait for amniocentesis, early anomaly scan can be considered for the patient, and in which we can pick up another soft markers. And if there are multiple soft markers, then we can always counsel the patient that invasive testing is required rather than going for NIPS.
Thank you, Dr. Annie. Yes, sometimes we wait for 16 weeks, followed by early anomalies 15 weeks, then early anomaly scan, followed by amniocentesis if we see some other soft markers along with it. But yes, CVS remains a gold standard diagnostic test. Thank you, Dr. Annie. Now, Dr. Kanchi, how would counseling differ in an IVF conceived pregnancy?
See, with IVF, if such a patient is conceived with IVF and is a singleton primary gravida, so probably counseling is usually very balanced and is very compassionate and actually non-directive, because usually in IVFs their anxiety and emotional investment are on higher side, but still because the risk is 1:115, 1% as Dr. Ritika said. See, it is very important to make them understand that what is known, what is not known, and what actually any test can offer. So if I have to counsel a patient with this kind of report, see, NT is on certainly higher side. With increased NT, there are certain other things apart from, Downs and Taus and Edwards. We can deal with single gene disorders or micro deletions also. So probably we counsel them in a very balanced way and tell them that yes, invasive testing is a better option than NIPS. But then if they're very anxious about the same, you have to understand what the patient wants to listen to you actually, and what the patient actually wants from you. So you have to explain that invasive is a better option. But then if they're not ready for a needle, then yes, NIPS first, and then probably if they an early anomaly scan, and then according to the whatever is there in the early anomaly scan, and then go ahead. I think here I would not advise them a CVS. Basically, I would ask them to wait till 16 weeks, probably offer them an NIPS, and then see on the early anomaly report what is the scan like. And then if we see more abnormalities or any structural malformations, then yes, amniocentesis probably.
Yes, because IVF patients,
I just want to add one small thing with the permission of the moderator, since NT was the question which raised the risk.
Yes, ma'am.
So fetal echo is also very important.
Yes, ma'am. Yes,
cardiac anomalies is the second most common cause after aneuploidy for an increased NT. So I think fetal echo also should be included.
Yes, in IVF patients, since they are more anxious and they have invested so much, sometimes we need to go with a 15 to 16 week early TIFA, followed by any other soft markers are there. And yes, as ma'am said, fetal echo is very important in this case. Next, this is a gray zone basically for Dr. Vidhi. Ultrasound is otherwise normal. Can this fetus still be chromosomally normal?
So, ma'am, I just wanted clarification on this. Have we done the diagnostic testing or no? It is just
ma'am.
no testing has been done. This is the result.
This is the result. Patient came to us with this NTNB scan along with the dual marker report, the combined screening, basically.
So actually, there is a very high chance that the fetus can still be chromosomally normal. With this risk result, with an NT of more than 3 mm, there is a 90% chance actually that there is no chromosomal abnormality, no structural abnormality. The fetus is completely alive and well, I mean, at birth. But yes, that 10% is what we were trying to rule out. So yeah, our counseling and discussions should include this, that there is a 90% chance that everything is perfectly fine, but we do need to.
Yeah. In this case, basically, we need to counsel the patient that there is a risk of having Down syndrome. It is not confirmatory test the baby is having a Down syndrome. So for confirming whether the baby is having or not, we need diagnostic testing. Next question. This is the last for the Dr. Annie Monga. What do international guidelines recommend in such screen positive cases? Just a simple one line.
So if there is a positive screening test, there is pre and post test counseling is of utmost importance, and patient's preference is to be taken into consideration. The options should be laid out before them, and this is your high risk, and these are the associated anomalies. And we follow the ICUOG, the Fetal Medicine Foundation, and the ACOG practice guidelines. And then the patient is counseled regarding that. And invasive testing is of importance, is a diagnostic test, and we cannot just go on with the screening if there is high risk for a patient, in such a patient.
Thank you so much. So I would like Dr. Monica to just compile this take-home messages, what we can take.
Thank you, Dr. Navdeep, for giving me this opportunity. So in this case, I would like to say that a very good counseling matters a lot, and we give a clear message to the patient that only the screening test is positive, and the baby is higher chances are that the baby will be normal. But yes, we need to investigate further. Multidisciplinary approach is needed. We need to include the genetic counselors, the fetal medicine expert, and the obstetrician. All of them counsel the patient together. And we need to tell the patient that it's not a final diagnosis. And we have to honor the patient choices also, and do according to the patient choices and what is good to the patient. This is what I would like to summarize.
Thank you, ma'am. As Dr. Navneet already told us, this is basically this patient with all these reports come in intermediate risk. So in this, counseling is very important so that patient doesn't take any decision harshly and should opt for a diagnostic test so that we know the diagnosis, then we can go ahead. Whether we go for CVS or with the discussion with patient, early anomaly scan, followed by, if possible, again, if markers are there, then we can go ahead with our amniocentesis, or if everything is normal, definite fetal echo is important. This is a contingent system through which we should go. Thank you so much. Now over to Dr. Ashvi for the second case.
So very good evening, everyone. I'm going to take up the second challenging scenario. So this is a 24 years old primary gravida patient. Her NT was done at 12 weeks and 2 days when her CRL was 54.3 mm. And the NT was 7.4 mm. Nasal bone was present. Her PAPE was 0.2 moms. Pre-beta HCG was 2.8 moms. Combined screening test came out to be positive. Her Down syndrome risk came out to be 1:8, and her trisomy 18 and 13 risk, it came out to be 1:2. So my first question is for Dr. Annie, as Dr. Nidhi is not here. So looking at this first trimester screen, what are the major red flags that immediately stand out to you? Am I audible?
You are audible, Dr. Ashmi. Please show the first slide again.
Yeah. Yes.
Okay.
My question is for Dr. Annie. Looking at this first trimester screen, what are the major red flags that immediately stand out to you?
Am I audible?
Yes.
Okay. So the first thing that is alarming is that the nuchal translucency measurement is 7.4 millimeters, which is well above the 3 millimeters cutoff for any for our NT measurement guidelines, and this is the first alarming thing. And then the PAPE levels, it is extremely low, that is 0.2 mm, which is well below the cutoff of 0.4 to 0.5. And then we have raised beta HCG also, that is 2.8 means of median. And so these values directly raise our concern that the fetus must be carrying a chromosome, an aneuploidy or some genetic disorder.
So very well said. So there are three red flags actually. Most important one is NT, then it is low PAPE, and then elevated beta HCG in this report. So moving on to the next question. This question is for Dr. Ashish. The NT here is 7.4 mm at 12 weeks. So at what threshold does NT become clinically significant? How does prognosis change as NT increases?
Ma'am, I think we can use a ballpark figure of 3 mm.
Yes.
Anything above 3 mm would be above 95th centile for the NT-NB scan window, which is 11 to 13 plus 6. And above 3.5 is more than 99th percentile. So that's alarming.
Yes. So anything that is above 3.5 is high risk, and above 6.5 is absolutely alarming. So moving on to the next question. This is for Dr. Ritika. How much importance should we give to the dual marker result versus the ultrasound? What, according to you, is more grave, the ultrasound finding or the dual marker report? What will get more weightage in this report?
Hello, Dr. Ashmi. I think pre-NT, obviously, I mean, it's too thick, 7 mm. But I mean, we also do keep the dual marker report at the back of our mind. So both the moms, the HCG and the PAPE moms, are actually in the typical trisomy 21 traditional range. Your HCG is more than 2, PAPE is less than 0.5. So this becomes a part of our counseling, like it's there at the back of our mind. So when we counsel these patients, so traditionally such high NTs, you generally, more than 5 mm, you generally tend to think about Turner syndrome or rhizopathies. But in this case, Down syndrome is something which will probably, I don't know what the final diagnosis was, but so maybe when we offer counseling, we probably just wait for the QFPCR report. And as Dr. Vidhi said, in the previous case, so sequential testing, and if trisomy 21 is ruled out, then definitely we do offer further testing for rhizopathies. But both are important. But obviously, NT, such a high NT, had, even if the HCG and the PAPE values had been normal, this would have been very, very significant.
So with such a increased NT, we have to think beyond karyotype also.
Yes, definitely.
So next question is for Dr. Vidhi. With such a markedly increased NT, would you still consider this simply a screen positive report or clinically almost diagnostic until proven otherwise? Would you consider it as a screen positive report or almost a diagnostic report?
So I wouldn't treat it as merely a screen positive. However, all that said, NT is never clinically diagnostic. It is still a marker. It still needs to be tested further. We don't know what it is diagnostic of. We don't know what is the reason for this increased NT. So yes, there is a very, very high chance that there is something wrong. There is almost an 80, the FMF educational material helps us in this regard, and we can counsel the patient that there is actually an 85% chance that there is something abnormal. We still don't know what, and we need confirmatory testing.
Still, it will remain a screening test only. So only a highly suspicious screening test only. So we'll anyways have to go ahead for the diagnostic test.
Yes.
Okay. Thank you, Dr. Vidhi. So next is again for Dr. Annie. Now, this report shows high risk for both Down syndrome and also for trisomy 13 and 18. So since these conditions usually have different biochemical patterns, as Dr. Snigdha told, that the beta HCG will be high in Downs and it will be low in trisomy 18 and 13. How do you explain this overlap of Downs and trisomy both? Both have come out to be high risk. How do you explain that this as per the biochemical markers?
So as per the biochemical markers, since PAPE is seen to be low in both, so this could be leading to the high risk in the aneuploidy screen. Also, the NT value is also taken into the combined screen. It is not just the biochemical parameter. So that is why the exponentially high NT value and the low PAPE was there. So this has come out to be positive for both the trisomy 18 as well as trisomy 21.
Basically, high NT has influenced the whole algorithm, bringing
the whole FPL algorithm. Yes.
Report like this. So, Dr. Annie again, once we receive a report like this, what will be the immediate next step in the evaluation? Immediate next step.
So at this gestation, there should be post-test counseling. Fetal medicine specialist along with the geneticist should be there. And for early diagnostic at this gestation, CVS can be offered to the patient so that we can reach at a diagnosis earlier, as compared to that we let the patient go on to have increased gestation. So that will not be adequate in this scenario, since there is already highly increased NT and such a positive screen. And if the patient is still not convinced, and in that scenario, we can consider amniocentesis after 15 weeks if there are continuing to be
so
soft
our very
markers
first step will be counseling.
Counseling, yes.
We'll counsel, we'll give all the options, all the diagnostic options to the patient. If they agree for CVS, good enough, else we'll motivate them for amniocentesis. So next, please, for Dr. G. In a patient with NT of 7.4 mm, the NIPT sufficient, not of course in your patients, or should invasive diagnostic test be recommended directly?
See here directly.
NIPT for routine obstetrics, not for IVF.
So see, NIPT is an excellent screening tool, but it remains non-diagnostic and it may miss important chromosomal and genetic problems. So here in this situation, because it is such a high NT, and NIPT actually can just delay the diagnosis. And it may miss certain conditions also. So here directly CVS actually should be advised to the patient.
Right. So in case patient refuses CVS, then we have to tell them that at least NIPT
then an
is
early anomaly scan and then amniocentesis.
If the patient refuses CVS, we'll motivate for amnio, and if refuses both invasive diagnostic, then we'll tell them that at least NIPT, bare minimum.
Yes.
Dr. Kanchi again. How will you counsel the parents when the screening test is high, but the diagnosis is still not confirmed? Our CVS report में जो karyotype है, that has come out as normal. So, but our NT was high, our screening test the risk was also very high. How will you counsel this patient now?
Here again, the counseling has to be very balanced and actually non-directive. We have to be actually very empathetic towards the patient, though the report has come out to be normal, but with such an high NT structural abnormalities and then other congenital heart abnormalities, we have not ruled out still. So probably we have to tell the patients that yes, probably you do not have Downs, but then there are other probabilities also, other genetic problems also, and sometimes they can have a pregnancy loss also. So we have to be we have to make them understand very gently and in a non-directive way, and we have to give them emotional support as well for the same. So, and then we can again discuss the option of early anomaly scan, and then probably if everything is fine, they can continue the pregnancy, and if not, then they might have to decide on their own.
So still not a point where we can reassure the patient. So we have to tell them the other possibilities beyond a normal karyotype.
Yes.
Okay. So Dr. Vidhi, what is the role of chromosomal microarray in this setting? And would you consider exome sequencing? I think we have already discussed this. If you would like to take it quickly. Dr. Vidhi?
So yes, I would definitely do, as Dr. Ritika said, NT more than 5 mm. There is a significant chance of rhizopathies. Once I would definitely do a microarray, and once my microarray is normal, I would like to move on to do an early anomaly plus order an exome on the stored DNA.
Yes. So moving on to next question. If the karyotype and genetic testing eventually come out as normal, what residual concerns will still remain in a fetus with NT so high? Dr. Ritika. Dr. Ritika is there?
Yeah, so I think I'm audible now. Yeah.
Yes.
So it all depends on what genetic tests have been done. So if we are talking about exome also in this case,
we have done karyotype, chromosomal microarray, and also the exome sequencing, and everything has come out as normal.
Yeah, so I think we are presuming we are somewhere. So had we done a CVS in this case, we are somewhere around 17, 18 weeks of gestation at present, because generally in practice, exome will take about a month. So at this point, we will do an anomaly scan at around 18 weeks. I'm presuming we must have done at 16 week scan by now. So at 18 to 19 weeks, we'll be doing an anomaly scan. We'll again be having a look at the nuchal fold thickness. Then we'd again look if there is any other structural abnormality. As I said, there could be problems with the lungs, there could be a problem with the heart or with the bones. So there are other conditions also. So if everything else is normal, so there might be that by 19, 20 weeks, we are seeing fluid in other places also. There might be ascites, pleural effusions. But presuming if everything is normal, all your genetic tests are normal.
And also fetal echo, as Dr. Navneet mentioned.
Yes, so we look at the heart in an anomaly scan also. So if everything looks normal structurally in the baby, if the nuchal fold thickness is settling, if there is no other fluid collection, then I would just say wait till 22 weeks, because at some point of time you have to tell the parents, in spite of all the non-directive counseling, you have to tell the parents that you can continue with this pregnancy, or you cannot continue, or you should not continue, or whatever. So I think 22 weeks probably. So by 22 weeks, we would have a pretty good idea of how the baby is developing, whether there's any additional growth restriction also which is developing. So I think a lot of these things, there's 15% chance in my practice with an NT of 7.5. I have never come across a case where everything was normal and everything turned out to be normal. So for me, the cutoff has been 4.5. So that's the maximum NT at which I have seen a completely normal baby being delivered. 7 mm, but then there are case reports. So there could be some lymphatic abnormalities where as the lymphatic channels develop, everything settles down. But I think by 22 weeks, if everything is normal, then I'd probably say that yes, go ahead. In literature, there are some reports about an association of a thick NT with autism spectrum disorders and ADHD. But I think a lot of that can be ruled out if you're doing an exome sequencing, because a lot of them have some sort of a genetic abnormality also. And I'm not sure whether they did an exome in those cases. I think they stopped at the microarray. So we provide all this information to the parents, but at 22 weeks, if my trio exome is normal, if my microarray is normal, if the baby is structurally normal on the baby, I'd say you can go ahead.
Okay. Thank you, Dr. Ritika. So next is for Dr. Monica Agarwal. Ma'am, what are the most common mistakes clinicians make while counseling screen positive patients?
Thank you for the question. So here I would like to say that the most common mistakes the clinician make while counseling screen positive patients is they kind of jump to the diagnostic aspect. People are quick to jump that such kind of NT, this high NT, and this baby is abnormal. So we have to be very clear that the screening is very different from the diagnosis, and we have to kind of counsel the patient empathetically that this still is a screening and we need to confirm it with further tests, and maybe could be a chance that this baby will be normal in future. So we have to be very clear about the screening test and the diagnostic test. The language should be very clear, that we don't use words like mongolism, down syndrome. We don't use very alarming words, abnormal baby, like these. We have to give reassurance to the patient, and we include other specialities like fetal medicine experts, and we kind of show emotional sensitivity towards the patient, and we kind of give hope to the patient that yes, with diagnostic test we'll be able to reach a conclusion whether the baby is normal or not, because the patient basically wants to see whether the patient can continue the pregnancy or they need a termination. So this is what we
So
need to.
counseling is, thank you, ma'am. So counseling is very, very important in these kind of patients. Monica Narang, ma'am, what is the one key message you would like the audience to remember when dealing with markedly increased NT?
Thank you for the question. Again, coming to just to put it like this only, we have to counsel the patients again that these tests are basically screening tests that we are doing. And the probability of chromosomal abnormalities that we will be telling them, or they are not confirmatory tests. But yes, in this scenario, when the increased NT as NT came, so definitely we have to counsel them that there are more tests available for diagnostic tests. Also, we have to counsel them probably, and at the end of the day, we have to let them know diagnostic tests again that we are advising come with small risk of pregnancy loss also. So these things we need to explain. And yes, pre-test counseling and post-test counseling both are equally important.
Yes. So thank you, all the experts and panelists. So here are our take-home messages for today. Markedly increased NT should never be estimated. Risk extends beyond the common trisomies. Normal NIPT or karyotype will not eliminate the residual risk. Early fetal medicine referral is extremely essential. We have to offer the invasive test with chromosomal microarray in patients with such high NT. Detailed anomaly scan and fetal echo are again mandatory, and counseling should remain evidence-based and empathetic at the same time. Thank you so much.
With permission of the moderator, Dr. Ashmi, can I make one comment?
Surely, ma'am.
My comment is here is the importance of a late anomaly scan, which we do. I think Dr. Ashish can also throw some light. Between 24 to 28 weeks, sometimes anomalies like hydrocephalus or something, they may be picked up late, they may be associated with some gene disorder. So in these patients, if the first anomaly scan has been done somewhere around 17, 18 weeks, then we repeat a 24-week scan also. Especially if the increased NT and we are continuing the pregnancy, everything has come normal, still ultrasound is done at 24 weeks. That's what we follow in our genetic clinic.
Ma'am, I would like
Dr. Ashish, can you throw some light on this?
Ma'am, yes, I think you're right, because if the baby was having an increased NT, the patient would have undergone an early anomaly scan. then it is always advisable to do a repeat anomaly somewhere after 22 weeks, because certain subtle findings which might be missed in the early anomaly scan can be covered up for. And if there's any developing anomaly, that can also be taken for or assessed at that time.
Ma'am, here, Navneet ma'am, I would like to add a case scenario here. There was a patient of mine, 26 years old, primary gravida. Her NT screen was absolutely normal. Her dual screen was normal. Her quadruple was also done. That was also normal. Her level 2 ultrasound at 18 to 19 weeks was also normal. We picked a strange thing, a large head around 23 weeks for this patient. Extreme hydrocephalus in this patient, which was around 23 centimeter. And after the expulsion, it was diagnosed to have Noonan syndrome.
So that's what I'm saying, no? So 24 weeks can important. Yes. In this scenario.
Patient had come to us at 23 weeks for fetal echo, when surprisingly the radiologist just saw the head looked extremely large. Then we did a level 2 repeat again, which was confirmed from another center. And then we did the expulsion because it looked absolutely terminal. And then it was diagnosed to be Noonan syndrome post-expulsion.
Thank you.
On autopsy.
So you have the clinical experience also. Okay.
I would like to make a comment on this. There are multiple systems actually, mainly the renal system and as well as the nervous system that actually has anomalies, mid-trimester anomalies, which are detected later on only, which are evolving anomalies and which usually are detected later in the trimester, in the second trimester. So while doing ultrasound, not only fetal biometry is mandatory, not only fetal biometry should be done, but then ruling out anomaly at those gestation as well is one of the important things. So
yes, around 24 weeks, even for low risk patients sometimes.
Yes, even for low risk patients.
So I think with this all, we had touched each and every corner of the first trimester aneuploidy screening. So thank you so much, panelists, for your valuable, brilliant inputs. Thank you, experts. Thank you, chairpersons and moderators, our lovely Ashpi, Aluna, and Navdeep, my ex-senior residents. And thank you for creating a background. Dr. Snigdha, you have a brilliant presentations. And all of this, thank you, our dignitaries, our senior mentors who have definitely expert views after all this discussion. And thank you, Ragini ma'am, for giving us this platform. We will continue. And next time when we are going to conduct a webinar, we will continue with the second trimester aneuploidy screenings. So that with this, definitely we are going to cover one spectrum of a clinical scenario for a fetus examination. So I would like to thank each and everyone. Thank you, Ragini ma'am. Thank you, Dr. Vineet. Thank you, Dr. Navneet. Thank you, Dr. Monica, and all other dignitaries and my dear friends for joining us. Thank you, Dr. Ritika, Dr. Ashish, our experts, Dr. Vidhi Hathi, my sweet junior, and everyone to be here. Thank you so much. So
Thank you, ma'am.
for NIGF annual conference also on 18th and 19th. Okay.
Thank you, Dr. Bharti. Thank you very much.
Bye. Okay.
Thank you, Dr. Bharti, for having
you, ma'am.
Thank you so much. Thank
Okay,
you.
Bye, everyone.
Okay. Bye.